Hello, my name is Joel Feger, and today I will be covering Chapter 55, Hemostasis and Thrombosis. We'll explore how the body stops bleeding, prevents unnecessary clotting, and what can happen when these processes go wrong. Hemostasis is the body's response to vascular injury. In other words, it stops blood loss by forming a clot. It involves platelets, blood vessels, and a cascade of clotting factors. Thrombosis, on the other hand, is the inappropriate clotting without an injury. When inappropriate clots form, they can travel to the heart and the brain, causing life-threatening conditions like strokes, heart attacks, and pulmonary embolisms. So how does an appropriate clot form? The first step in hemostasis is vasoconstriction. When a blood vessel experiences trauma, endothelial cells release endothelium. Endothelium causes blood vessels to constrict, thereby reducing blood flow. Similarly, direct trauma to smooth muscle and pain receptor reflexes also cause vasoconstriction. This reaction narrows the vessel, buying time for the platelet plug and coagulation steps to follow. This image shows vasoconstriction occurring right here and thus reducing the amount of blood loss. The second step in hemostasis is the formation of a platelet plug. Platelets adhere to exposed collagen via von Willebrand factor and GP1B receptors. This triggers a cascade of intracellular signaling. You can see the complexity of this in the image on the right. Phospholipase C is activated, IP3 causes calcium release, and platelets change shape, exposing phosphatidylserine, which provides a procoagulant surface. Activated platelets then release ADP, thromboxane A2, and serotonin. These chemicals recruit and activate nearby platelets via a positive feedback loop. GP2B and 3A receptors allow them to bind fibrinogen and aggregate. This forms a temporary plug, as shown as the image on the bottom, right here. The third step in hemostasis is the coagulation cascade. The coagulation cascade reinforces the plug with a fibrin mesh, stabilizing the clot. There are two initial pathways. The intrinsic pathway is triggered by exposed subendothelial collagen and involves factors 12, 11, 9, and 8. The extrinsic pathway is activated by tissue factor binding factor 7. Both of these pathways converge into the common pathway at factor 10, which, with factor 5, activates thrombin from prothrombin. Thrombin then converts fibrinogen into insoluble fibrin. Factor 13A cross-links fibrin strands to stabilize the clot. You can see the pathways over here, and then the green strands down here in the bottom image is the stable clot held together by fibrin. Now that we understand how a stable clot forms, let's take a closer look at the clot itself. As we just discussed, thrombin is the protein responsible for converting fibrinogen to fibrin. However, thrombin is more than just a fibrin converter. It is the central amplifier of coagulation. It activates factors 5, 8, and 11, and also activates platelets via PAR1 and PAR4 receptors. In addition, thrombin binds to thrombomodulin on endothelial cells to activate protein C, helping regulate clot formation. Thrombin bridges procoagulant and anticoagulant roles, ensuring clot formation is tightly controlled. Another crucial aspect of the clot itself is the cofactor vitamin K. Several key clotting factors require vitamin K-dependent gamma carboxylation to bind calcium to function properly. These include factors 2, 7, 9, and 10, as well as proteins C and S. Vitamin K must be recycled by an enzyme called vitamin K epoxide reductase, which is the target of warfarin, a common anticoagulant. Blocking this enzyme reduces the production of active clotting factors. We'll discuss pharmacologic inhibitors further later, but here's another picture of the intrinsic, extrinsic, and common pathways. We've seen how clotting factors build a stable clot, but without proper regulation, this process can go too far. Let's take a look at the body's built-in anticoagulant systems that help prevent excessive or inappropriate clotting. The body uses natural anticoagulants to mediate hemostasis. Antithrombin 3 inactivates thrombin and factor 10. Protein C, once activated by the thrombin thrombomodulin complex, degrades factors 10A and 8A. Protein S acts as a cofactor for protein C. Heparin sulfate on endothelial surfaces enhances the activity of antithrombin. Most clotting factors are also degraded by serpins or deactivated naturally over time. Deficiencies in these regulators, such as antithrombin deficiency, increase the risk of thrombosis. Just as the body has natural mechanisms to control clotting, we can also use targeted medications to interrupt the clotting process for high-risk patients. There are two main types of drugs we can utilize: antiplatelet and anticoagulants. Antiplatelet drugs include aspirin, which inhibits COX-1 receptors, which reduces thromboxane A2 and thus platelet aggregation. Clopidogrel blocks P2Y12, decreasing ADP activation. Abciximab, which blocks the GP2B and 3A receptor, prevents platelet binding. Anticoagulants such as heparin and warfarin. Heparin enhances antithrombin 3. Warfarin, which I mentioned earlier, inhibits vitamin K recycling by blocking the vitamin K epoxide reductase. So now that we've seen what goes into building the clot and regulating the clot, the final step in hemostasis is the breakdown of the clot, also known as fibrinolysis. After the clot forms, platelets contract to condense the clot and seal the injury. They also release growth factors such as PDGF and VEGF to promote tissue repair. TPA activates plasminogen, converting it to plasmin. Plasmin then digests fibrin into soluble fragments called D-dimers. Clinically, TPA is used as a clot-busting drug in early stroke and heart attack treatment. So here in the image, you can see our clot here. It sealed the wound, and here are those D-dimers that have been broken down by plasmin. So just as the body self-regulates the building of the clot, fibrinolysis must also be carefully regulated to prevent premature clot breakdown. Two key inhibitors are alpha-2 antiplasmin, which binds and inactivates free plasmin, PAI1, which inhibits TPA, and UPA prevents excessive activation of these enzymes. These mechanisms help maintain a balance between clot stability and breakdown. And here is the image kind of just visualizing that. Some individuals are born with inherited clotting deficiencies, such as hemophilia A, von Willebrand disease, and even some platelet receptor defects, such as the Glasman thrombocythemia disease and the Bernard-Solier syndrome. These disorders lead to prolonged or excessive bleeding after injury, and some even present with spontaneous bleeding. So, to summarize, hemostasis occurs in 4 coordinative steps. 1. Vascular constriction. 2. The platelet plug formation. 3. The fibrin clot stabilization. And finally, 4. The clot retraction and fibrinolysis. Thrombin plays a crucial role in the formation and regulation of clots. Vitamin K, natural anticoagulants, and clinical inhibitors all play key roles in maintaining balance. Disruptions in this system can lead to life-threatening bleeding or dangerous thrombosis. And finally, we have some multiple choice questions. Number 1, which of the following is part of the processes that activates platelets after a blood vessel is injured? We have A, release of ADP, B, release of insulin, C, binding of hemoglobin, or D, release of antibodies. And the answer here is, of course, release of ADP. Number 2, how do antiplatelet drugs like aspirin and clopidogrel help prevent clot formation? We have A, inhibit platelet activation, B, bind to von Willebrand factor, C, increase fibrin formation, or D, stimulate platelet production. The answer here, A, these are both antiplatelet drugs, so they inhibit platelet activation. Number 3, which pathway is involved in blood clotting that leads to the formation of fibrin? We have A, the extrinsic pathway, B, common pathway, C, the intrinsic pathway, or D, all of the above. And if we remember, the extrinsic and intrinsic both combine at factor 10 to form the common pathway, so the answer here, D, all of the above. Number 4, which of the following coagulation factors is vitamin K dependent? This one is B, factor 2, also known as prothrombin. And finally, which condition is caused by a deficiency in factor 8 and leads to excessive bleeding? This one is hemophilia A. Thank you. I hope everybody learned something.